you.
Yeah.
Okay, good morning,
Yeah.
everybody.
Yeah.
Welcome to Medical Grand Rounds. It's always nice to see faces in person. So, yeah, that's okay. I'm shouting. Maybe if people stop talking, then they can hear me. I don't need it. All right. Good morning. I apologies to those at home for shouting. So hopefully people can hear me. Just before we begin, I would like to acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I will be handing this over to Dr. Clarence Wong to do the introductions. But I also wanted to just send a little reminder that right after this, there is a special Dean's lecture in Snell Hall, so it'll be a little trek over. It's Andre Picard speaking on tipping point. Are we finally ready to tackle the crisis in healthcare? So if you're able to try and make it over. And with that, I will hand it over to our division director and section chief, Dr. Clarence Wong.
Thank you, Dr. Kassam. So good morning, everyone, and good morning those online. So it's my pleasure to welcome everyone to the Richard Shabanic Ron Wenzel lectureship. So this is the one of the most important lectureships that's sponsored by the division every year. And this is our 23rd year. And so in some ways I was looking back and I thought maybe I'm confident it's the 23rd year. And it's an incredible list of lectures we've had over time. So we've just gone through our 100th anniversary to the department, but just to remind everyone again, division started in 1967 and Dr. Shabaniak and Dr. Wenzel both finished med school here in the 1950s. They, I think, quote unquote, said the GI training was terrible here. So we went away to the US, got our fellowships, came back, and really with that firm sense, wanted to start gastroenterology in Edmonton and at the University of Alberta. And from there, and I could say, just look at what's happened, you know, it's a large division, gastroenterology and hepatology. And I think with that, it's very fitting that I introduce our esteemed speaker today, Dr. Nora Thoreau. So Dr. Thoreau is the Neil Kaplowitz Professor of Medicine and the Chief of GI Liver Division at the Keck University at University of Southern California. She is world-renowned and respected for her work on viral hepatitis, fatty liver disease, and focus on patients with cirrhosis and liver transplant. I think she most of all, she's a transplant hepatologist. She gave us a great talk last night on alcoholic hepatitis and liver transplantation. And she just finished as the AASLD president and coming in. So I think with that, let me introduce and welcome Dr. Nora Thoreau.
Right. Thank you. So first of all, just let me tell you how wonderful it is to be here. Really, I am humbled really by this honor, and it's so wonderful to be back in Edmonton. And I'm going to acknowledge my colleagues, Leah Gremlich and Mang Ma. We were all in the same class of 1987. It was wonderful to see us on the wall. It was really, really pretty remarkable yesterday to have time to visit the facilities and to see and connect with colleagues. So really, thank you so much for this invitation. I am a transplant hepatologist, but today this lecture is not going to be involving anything related to transplant. I can tell you that. And I'm going to just give my disclosures. Not most of which are not relevant to this talk, but I always put them up there. But I thought I would, you know, in thinking about this lecture, I thought about many things I could talk about. I have many passions, but I was reminded that Hep B was my start in terms of clinical research. When I finished my GI training at the University of Toronto, I, of course, went away to sort of do more. And I went to UCSF fellowship, actually. Just my topic at that time, my grant was on sort of preventing hepatitis B reinfection in patients who were going through liver transplant. And at the time, there were really no therapies available to do that. And patients who were going through a transplant were routinely getting reinfected with the virus and then losing their grafts within, really a short period of time. So my first publication that came out of that research was published in Hepatology, and it was about using hepatitis B immunoglobulin to prevent reinfection in the grafts. And then I was thinking, just kind of all the way through, this is the most recent publication that just came out. My this month's publication, just to sort of say my track through Hep B has continued. This work was supported through an NIH cooperative grant. There was 10 centers that studied hepatitis B for more than a decade. And our focus in that was to try to understand how to get more patients to functional cure, my topic today. And so I thought that it was kind of nice to kind of bookmark kind of where I am in my career by these two publications. And I will also want to just kind of acknowledge really U of A and the individuals here, especially Lauren Terrell, really instrumental in this important development back in 1998, where we came to have the first nucleoside analogs available to treat hepatitis B. And his team really were instrumental in bringing those first drugs to market. So really remarkable. And it happened in 1998. So while I was at UCSF, these drugs became available and really have completely changed really the whole landscape for hepatitis B treatment. And then what I'm going to focus on today is really the future. And now we're working on a whole new level really of drug development focused on achieving functional cure, which I'm predicting we'll have our first available probably by 2026. So that's my sort of setting the stage for today. Just to give you a little bit of that historical perspective, as I highlighted, lamivudine, which was the first drug approved, came out in 1998. There's been several drugs that have developed since then. The last one to be approved was in 2016, it was tenofovir alafenamide. And then since that time, we really had no further drug development for hepatitis B. But as you'll see, and I'm not going to take through every drug that's being developed, but we're now in this kind of era of HBV cure, because all of our therapeutics up until this point have been focused on really control. They're not really curative. They're very good at suppressing HBV replication, and we've gotten really excellent outcomes with that, but we've really not gotten to cure. So now the focus is really on that particular goal, and much of what I'm going to sort of present today is really looking at that. But, we have curative therapies for hepatitis C, and many, I think, well, if we've done it for C, why can't we do it for B? And B is just a very different virus, and it has some very unique aspects that make acquisition of cure, I think, much more of a challenge for us. And I'll highlight just a few of them here, kind of taking you back to your virology around hepatitis B. But remember that the hepatitis B virus kind of produces a lot of antigen, like high levels of surface antigen that are circulating continuously. And it's thought that that's kind of part of its mechanism for persistence, because it exhausts the immune system by having this very high production of surface antigen. The other aspect, of course, is there's a closed circular form of the DNA that's sequestered within the nucleus of hepatocytes. And our current antivirals can't access that source, that reservoir for hepatitis B infection. So that's kind of one of the key aspects as to why we can't get to cure. And then finally, this is also a virus that integrates into the host genome. And we know that linearized HBV DNA gets inserted into the host DNA, and that then becomes also a source for producing surface antigen. And that, again, accounts for why we see such high levels of surface antigen that are circulating, contributing to this kind of goal of persistence. But this is also really important from the point of view of thinking about complications of hepatitis B. The integrated HBV DNA is thought to be really quite important from the point of view of cancer risk. So these are unique aspects. Our current therapeutics, as we move to the future, are trying to address some of these aspects, but it has made the kind of challenge of getting to HBV cure quite different from hepatitis C, which doesn't have any of these kind of characteristics. Now, I wanted to start out by sort of defining the terms I'm using, because functional cure is not something that maybe has been around as long as other words that we use. And so I want to just kind of outline what we are talking about when we call functional cure. And what I'm looking at here on the cartoon is sort of HBV DNA levels, and also surface antigen as kind of the markers to define cure. And you'll see a little bit of a table on the right there. So currently with our nucleoside analog therapy, we achieve partial cure. That's the term used. Partial cure is somebody whose HBV DNA is undetectable, but their surface antigen is still present. And if you were to do a liver biopsy, you'd find cccDNA in the liver, and they still have integrated HBV as well. But we're very happy with partial cure. That's what we've been achieving thus far. But the goal of the new therapies is to move to functional cure. And I'll be explaining why we think that's important. But functional cure is where you lose surface antigen and acquire antibody. So functional cure is loss of HBV DNA, but loss of surface antigen. So you're going to hear a lot of what I talk about today is about losing surface antigen as a therapeutic endpoint. But keep in mind that functional cure, and the reason we use that term functional is because you still have the cccDNA and you still have the integrated DNA as still present. And so potentially a risk for reactivation under certain circumstances. And you'll see other terms that are sometimes used to determine sort of the holy grail of HBV cure, which is if we can get rid of the cccDNA, then we would call that a complete cure. And if you can get rid of it out of the host genome, so-called sterilizing cure. Currently, therapeutics for hepatitis B in terms of drug development are focused on functional cure. We don't feel quite that we're within the realm of being able to get to complete or sterilizing cure, but that might be something we can hope for in the future. So I'm going to use the term functional cure, but know what it means is that we've got HBV DNA that's undetectable and loss of surface antigen. And that's, as I said, is kind of what we currently achieve. Okay, so that's to sort of set the stage. So what I'm going to do in the next kind of 30 minutes or so is to really, first of all, kind of highlight why there's a need for curative therapy, review what we achieve with current treatment options and some of the nuances around how we are approaching treatment, and then shift to talking a little bit about where we are with functional cure. And I can't talk about hepatitis B because a lot of what I focus on in the realm of viral hepatitis these days is working towards elimination. And this is kind of a concept that was put forward by the World Health Organization back several years ago now, where they proposed that we should globally work towards elimination of both hepatitis B and hepatitis C. And that's what's kind of documented. And when they say elimination, what they're referring to is really getting mortality reductions of at least 65% and reducing new infections by 90%. That's how they define elimination. But for hepatitis B, they have other goals. And the other goals are to have 80% of patients who are eligible for treatment to be on antivirals, and that we get more than 90% vaccine coverage. Remember, Hep B, we have the perfect cure, really, which is to vaccinate everyone, right? If we vaccinate everyone, we'd be done. But that's sort of another goal. And so, you know, I wanted to just, before we sort of move into like, how are we doing here in Canada and the US, is really to say, how are we doing globally? And to sort of set the stage for why this is important. Still, there's like, this is kind of one of the most important chronic forms of liver disease in the world. More than 75,000, million people who are infected. You can see geographically, of course, great differences with the predominance of disease in Africa and Asia. But what's interesting, you know, we all know that we have a very global community now, and with a lot of immigration, a lot of people on the move, Canada and the United States are very much the kind of countries that are having individuals from these parts of the world move to our countries. And so we are seeing this influx of individuals who bring with them their hepatitis B. It's estimated that even as of 2022, there were more than 1 million deaths related to hepatitis B. And that of those that are infected, those 275 million individuals, somewhere between 25 to 40% of them are going to die of complications of their chronic hepatitis B. So it just points to that importance of this as a disease. And this is kind of remarkable if you think about it, since we've had a vaccine since the 1980s. And then, as I just shared with you, we've had highly effective antivirals since sort of the late 1990s. So despite having those really important advances, still we're seeing more than 1 million deaths per year. Hence the reason why there's a call for elimination. And there's been a recent Polaris Observatory kind of update on how are we doing in terms of meeting those global targets. And this is data from 2019. They haven't updated it since, but this is the global snapshot. So again, you'll see on the left, about 275 million individuals who are infected. Of those, only 12% have been diagnosed so far. So the major issue we have is that most people don't know they're infected. So that's the problem number one. But even among those that are diagnosed, only 8% of those that are treatment eligible are on treatment. And if you think we're doing a lot better here in Canada and the United States, I'm going to tell you we're at about the 15% mark. So we're not doing that much better. So there's huge gaps in terms of both sort of knowing who's infected and then also getting those individuals on treatment. So my short answer is we're really not on track for elimination. So when they do a country update, both Canada and the US are not on target. There's no way we're going to meet the elimination targets by 2030, the rate we're going. And sort of speaks to the need for us to really move in many ways. And part of that, I think, is around an elimination strategy in terms of getting functional cure. So just to highlight, my summary number one, lots of deaths still. And that's really remarkable given the tools we've got in our toolbox to try to prevent deaths. Most are still undiagnosed. So we have to think about how do we increase awareness around infection? How do we think about doing screening strategies to identify, especially among individuals who are immigrants, for example. In the United States, we recently, in the last year, changed our screening strategy from doing a targeted approach where you screen individuals based on risk factors to doing a treat to test everybody once. And we did that because we realized we were missing individuals. So maybe Canada has to follow suit, but that's what the US decided to do, is do a test all adults once. And then, of course, rates of treatment are lower than expected. I'm going to be spending most of my time on that particular issue. So today, if you look at the guidelines on treating hepatitis C, we have basically 3 drugs that are recommended. These nucleoside-nucleotide analogs are entecavir and then 2 versions of tenofovir DF and tenofovir alafenamide. These are wonderful drugs. They are safe. They're highly effective without really risk for resistance. You can use them in almost really anybody. Think about it. We can use it in pregnant women. We can use them in individuals who are immune compromised. We can use it in transplant patients across the gamut. There isn't a patient that you can't use these drugs in. So it's quite remarkable to have such a safe and highly effective therapy available. And it's quite easy to kind of make decisions about treatment. You can kind of use any of them. They work really well. There are some nuances around sort of selecting one over another. For example, for individuals who are older and at risk for bone or renal disease, we would avoid tenofovir DF because there is some potential for toxicity related to bones and renal and kidneys. But really, that's the main thing. HIV infection, we have to think about, prior lamivudine exposure, and in pregnancy, we have data basically for tenofovir. But aside from that, really, it's very easy to kind of pull the trigger on, like, I'm going to treat, and I could use one of these very safe and effective drugs. And what we've learned, because we've had these drugs available since the late 1990s, so we have now several decades of use of these drugs, is that we know that if we use them in the eligible populations, that we can achieve all of these things. So suppression of HBV DNA with these drugs leads to lower rates of cirrhosis, can reverse fibrosis and cirrhosis. You see cirrhosis reverse. You prevent decompensation or reverse or turn around decompensation. I'm going to show you data on HCC, and overall it leads to reduced liver-related mortality. So really, these are really highly effective drugs. And some have argued, well, we've got what we need. Why do we need new drugs? I'm going to try to make the argument that we still have some ways to go. But one of the kind of limitations of our current nucleoside-nucleotide analogs is that we don't get that surface antigen loss very often. So remember, we talked about functional cure. These drugs don't get us to functional cure very often, and I'll show you data on that. And the other thing is that this means that most of our patients, to maintain this suppression of HBV DNA, the majority of them have to stay on long-term, sometimes lifelong therapy. And so, there's rationale for thinking about, can we do better? So I mentioned to you that, we are not doing great in terms of getting those eligible patients onto treatment. This is data from the Global Hepatitis Task Force, where they're doing kind of a report card on countries and how we're doing with elimination. And they just put up the most recent data on Canada and the US. You can see we're both sort of not doing as well as we could be. This is the estimation of the proportion of patients with chronic hepatitis B in the country who have been diagnosed, who are eligible, and who are on treatment. And you can see that we're at best getting up to close to 20%. So a large gap in those eligible versus those who are on treatment. Of course, not everybody who has hepatitis B is recommended to be on treatment. We do treatment in a selective way based on risk of progression of liver disease. We treat this as a liver disease really much more than as an infectious disease. And so the treatment guidelines have really been targeting those that have active disease, as evidenced by ALT levels and HBV DNA levels for the most part. We, of course, still take into account the status of the liver disease and family history and use those to help make decisions. So if you look at the current treatment guidelines, and I put up here AASLD, which I was a part of putting together, but it's very similar to many other guidelines, including CASL, where we are using things like ALT, EN, just as an HBV DNA to tell us whether we should start someone on treatment. Again, we're targeting those patients who are at most risk for disease. But remember that if they don't meet treatment today, then you still have to do this serial monitoring because we know that the disease is very dynamic. So if today they don't meet the criteria for treatment, they might in 6 months, in 1 year, 5 years. So there's this need to really engage patients in care and keep them in care so that you can intervene with treatment at the right time. And that has been some of the complexities around managing Hep B, is this idea that it's a chronic disease, so there's this ongoing need for management. Think about it, if we had a functional cure that we could offer a patient and cure them, then that a need for that long ongoing monitoring would be removed. So simplicity would be brought into play. And there are many studies, I'm not going to show you those results, that show that compliance with actually doing the monitoring is actually very poor as well. So we sort of have a gap in our ability to deliver on the promise of treatment when patients don't follow up for monitoring. And I just put up, this is actually taken directly from the guidelines. It's a kind of the algorithm on how do you think about who should be treated. I'm not intending you to really actually look at the actual numbers. But just to know that in this box, if you are purple, that would be a patient you're treating. Blue is a patient we in the guidelines say you don't treat. But the gray boxes are basically saying, well, maybe you treat and you need more information. The idea being is that we have a lot of gray zones where it's not, we don't have very clear guidance on whether you should treat. And the reason for that is that sometimes patients they meet one criteria, like their ALT is elevated, but their HBV DNA doesn't meet the criteria. So we find all these patients sort of falling into this gray zone. And there's been several studies that have suggested that as many as a third of our patients, quarter to a third of our patients who present for treatment fall into the gray zone. And for me, gray zone is like my passion. I get to like think through all the nuances of if I'm going to treat or not. But when we want to roll out treatment to really a broad number of treaters, and we want more people to engage in treatment, we got to make it simpler. So there's been a lot of a big call for like making it simpler. And this just recently, the WHO put out a highly simplified approach to treatment to really speak to that question of maybe the guidelines are just too complicated and we just need to simplify. And remember, the WHO is not just writing guidelines for Canada and the US, they're writing it for the globe. But just sort of say how they've simplified it, okay? So what they basically are saying is a bit of, starting at the top, is they say if you have any degree of fibrosis, treat. That's the first thing. Second is if the individual has a viral load over 2,000 and their ALT is elevated, treat, okay? And then basically that's the end of it, right? And then in countries that don't have access to HBV DNA testing, like parts of Africa, ALT alone is a criteria to treat. So you can see there's this really effort to expand the access to treatment. And we in the US, and I know in Canada as well, we're sort of all redoing our treatment guidelines with this idea of how do we expand access to treatment, and do we all follow the WHO or do we do something in between? So just to sort of encapsulate where we are currently, HBV currently is controlled but not cured. We have very good drugs, highly effective, and yield excellent outcomes. But we have this issue of the gray zone, issue of the complexity. And so there really is this kind of movement towards a simplified guidance based on really viremia and an elevated ALT. Okay, so that's sort of where we are with current treatment. Now I'm going to shift a little bit more now towards functional cure. And how do we get there? So I have said since the beginning that S antigen loss is very infrequent with our current antiviral therapies. Here's the data. So this is looking at patients who start out either e antigen positive or e antigen negative. You can see that if you're e antigen positive when you start your nucleoside analog therapy, that you have somewhat a higher rate of losing surface antigen over time. For those that start out e antigen negative, the rate of S antigen loss is essentially 0. But overall, the rate is very low. And this is looking at 2, 3, and you can take it out to 5 years. When they've looked at sort of overall estimates, what I quote patients when I start them in an NA therapy, nucleoside analog, is that their rate of losing surface antigen is maybe 1 to 1.5% per year. So, most of them are going to be on treatment forever and for most of their lifetime. All right. Let me just skip past this one. What we're going to do, so what the focus is now is like, let's move more towards this surface antigen loss and try to think about, instead of having long-term indefinite therapy, is to move to S antigen loss and to do it with more finite courses of treatment. That's kind of the change and the goal that we now have. We don't achieve this very often with NA therapy. Can we do better in terms of getting surface antigen loss? Now, you might say, well, you did so well in terms of achieving all the important endpoints related to chronic hepatitis B with just NA therapy, less cirrhosis, less cancer, less deaths. Why do we have to get to surface antigen loss? Well, the answer is that we now have data that says while suppression is good, loss of surface antigen is even better. And here are data to support that. This is a Korean cohort, more than 5,000 chronic hep B patients who were initially started on NA therapy and then followed, you can see, up to 14 years. Drugs have been around for a long time, so we have a lot of data. And what they did is the patients that lost surface antigen during their NA therapy, remember it happens at a rate of 1 to 1.5% per year, so the number's not high, but those that lose surface antigen, which is shown in the dark line, you can see that their likelihood of surviving is essentially 100%. Their risk of liver cancer is essentially 0, compared to the patients that were on NA therapy, right? The NA therapy compared to an untreated patient is still doing great. But if you compare the treated patients, losing surface antigen takes you one step further to having a lower risk of those kind of complications. There are more data. This is a study from Hong Kong, similar study where they took NA suppressed patients, and what they're looking at is those that lost surface antigen, they're on the bottom, versus those that remained on suppression. And this study goes one step further and says not only is losing surface antigen better, but when you have patients on NA therapy, they have to be adherent. And if they're not adherent and you're not getting complete suppression, you can see their outcomes are not as good as well, which speaks to the challenge of having somebody on treatment for 10, 20, 30 years, is that they have to also be adherent to get the benefits. So wouldn't it be better if we just had more people lose surface antigen and more rapidly get to this point where they reduce the risk of liver cancer and of liver-related events to 0 as quickly as possible? Okay. So with this in mind, over the last, I would say, decade, there's been a lot of studies saying, well, can we do better with the drugs we have to get more surface antigen loss? And how might we do that? Well, there's been sort of basically 2 strategies that have been utilized. One is that we actually have PEG interferon available and is an approved therapy for hepatitis B as well. We don't use it very much because, of course, it's a more complicated therapy than NAs are. But there's been kind of a resurgence in thinking about using PEG interferon. Interferon is thought to be sort of immune modulatory as well as being antiviral, and maybe that's something that can get us more towards surface antigen loss. And so there's kind of 2 strategies that have been looked at in terms of an alternative to what we're currently doing. One is to take patients that have been on NA therapy for years, and then you add in PEG on top of it, a so-called add-on strategy for 24 to 48 weeks to try to get more of them to surface antigen loss. And the other strategy is to do a switch. The idea is you have them on NA and then you switch them to PEG to kind of drive them towards surface antigen. Both of them are PEG interferon-based strategies. So I'm going to show you some data on those. And then the other one that's received a lot of press is the idea of taking patients off NAs so that they get a flare of their hepatitis B and with that lose surface antigen. I'll show you some data around that. And in answer to the question of can these lead to improvements in rates of surface antigen loss, the shorter answer is yes. Actually, these strategies do work in increasing the rate of surface antigen loss, but I would say to you that effect is relatively modest. So let me just share with you the result. A little bit of a busy slide here, but look on the left first. So I'm showing you basically 2, one is a meta-analysis and the other was a randomized controlled trial where they actually did a PEG interferon add-on or switch strategy and compared it to staying on NA alone. What I can tell you is that if the patient stayed on NA alone, none of them lost surface antigen. Whereas those that switched or had add-on of PEG interferon over that period of a year, you can see that somewhere between 8 to up to 14% of them lost surface antigen. So it definitely drives patients towards surface antigen loss with at a greater rate than if they remain on NA therapy. We have clear data around that. The challenge, of course, with PEG interferon is shown on the right, right? And that's the side effects. And for those that haven't used a lot of interferon for doing treatment, I've done a lot in my career. This is not an easy lift. It's a lot of monitoring. And as you can see, side effects are pretty much uniform. And some of them can be serious. It can trigger autoimmune diseases, et cetera. So it's not for the faint of heart. So while it's an excellent strategy, it's probably not one that we would want to see as kind of being making it to the mainstream in terms of a strategy for getting more S antigen loss. But what about the idea of withdrawing the nukes? So here is a cartoon that kind of outlines what's this strategy. So here they take patients that have been on nucleoside analog therapies for at least 3 years. I'm going to make the point they don't do this in patients who have cirrhosis because patients with cirrhosis won't tolerate an ALT flare. So that's the first thing. But then what they do is going from left to right is you stop the nuke. And then there's a period of usually a few months where nothing happens. Their HBV DNA levels are low and ALT levels are still normal. But then you see HBV DNA come back. They get a virological relapse, as it were. That's the blue line, HBV DNA. And then usually a lag of a month, weeks to months, you get an ALT flare. Now that ALT flare could be very modest. It could go on ALT goes up to 40 or 50, and then it sort of settles back down again. Or it could be an ALT flare that goes into the thousands. And so, that's the uncertainty with this strategy, is that you have to be able to kind of tolerate having somebody go through the flare. And if you follow them, if you don't treat them, or if you treat them after they've got into the flare but started the treatment only then, you can actually get more S antigen loss. And so the outcome, when you look at them 3 years after you've done this, is that somewhere between 5 to 20% of them will have lost surface antigen. So this also is a strategy. But the challenge, of course, is that you have to kind of go through that monitoring phase. And there is a risk for flares. And this has been done in many, many studies. And actually, there have been reports of patients, having a flare that resulted in them needing a liver transplant, or even there have been deaths. So again, it requires a very adherent patient. It requires a very close monitoring on the part of the physician, but it is a strategy. And I'm showing you both the PEG interferon and the withdrawal strategies in part to say, yes, this works to getting towards surface antigen loss, but I'm also showing you this because when we think about HBV functional cure and the new drug strategy, the new drug therapies, those new drug therapies are using PEG interferon. And if you're thinking about a functional cure, the whole idea is you do finite treatment, you've got to stop it. So regardless of the treatment we're talking about, we're going to have to stop. And I think looking at what happens when we stop nukes gives us some idea of what we have to be doing and thinking about when we look at the new therapies that are coming. So my summary regarding the functional cure with current therapies is that we don't get functional cure very often with NA ongoingly, like as a long-term suppressive therapy. But if you can get functional cure, clearly it's better than having just HBV DNA suppression. So it kind of argues for why functional cure is important rather than doing NA therapy. PEG interferon and withdrawal of nukes is one strategy, but I'm going to suggest to you that's not great. And that really provides the premise for why we're moving towards new therapeutics. So in the last minutes of my talk, I'm going to just touch on the new therapeutics. If we think about kind of how we're going to try to get to functional cure, we can kind of lump the drugs that are in development into sort of broad categories. It's not that they just do one thing, often they do more than one. But we have drugs that inhibit viral replication. Our current nucleoside analogs are exactly in that category, but there's some new categories of drugs, capsule assembly inhibitors, entry inhibitors, monoclonal antibodies that are thought to also be relevant in that category. I mentioned at the beginning that the virus makes very large amounts of circulating surface antigen. So we believe that bringing down that viral load burden will be important towards getting functional cure. And so there are classes of drugs that are really relevant in sort of bringing down that antigen burden, and probably the silencing RNA drugs and that class are probably the ones that are most well known. And I'll be speaking a little bit about those. And then because we realize that really immune boosting seems to be really relevant, we see it with PEG interferon, that we can get more S antigen loss with PEG interferon. But there's a whole group of other immune modulatory drugs that are in development, including therapeutic vaccines, to get us towards surface antigen loss. So lots of drugs. There's more than 50 drugs in various phases of development. And I show this slide to really dazzle you, to really say there's a lot. This was just actually, I got it from the ASLD, a presentation on where we are with drug development. This comes from the HBV Foundation, which does kind of an update all the time. And this is really to say what drugs we have. It's the classes of drugs, but really to tell you the number we have. It's really remarkable. And the ones on the right here are the ones that are in phase 3. So we actually have 2 drugs that have already made it to phase 3, bepirovirsen, which I'll show you data on, and bulevirtide, which is actually a drug for Delta hepatitis. But really to have you sort of be the wow factor, right? We have a lot of interesting drugs, both antiviral and immune modulatory drugs that are in phase 1, phase 2, and even out to phase 3. So I'm gonna, it's kind of not really helpful, I think, to take you through every one of the drug classes and the various drugs that we have in development, because they may die by the time they may never make it to the finish line. We've seen many drugs already who have never gone past, early phase 2. But to let you know that we have really drugs of each of these classes that are in phase 2, with the exception of some of them are phase 1, but really very good development. So 5 is actually our current nukes. I'm going to talk about RNA, viral RNA interference, since that class of drugs, the siRNAs and ASOs, are the ones that have really come to dominate, at least at the moment where we are. And so I wanted to review that class. So that class is the number 3 in the figure there. What this drug class does is it targets the post-translational messenger RNA of all of the various transcripts, all the messenger RNA. So it brings down surface antigen, it brings down all of the various transcripts, so that you get both surface antigen going down, and you also bring down viral replication. And that is thought to be really important, that we're doing both of those things. And some people believe that also it's going to have some influence on cccDNA over time. So there's been a lot of interest in this class of drugs. And the one that only one I'm going to show you is bepirovirsen. And the reason I'm showing you this one, it's a drug that has made it through phase 2. These results were published in the New England Journal of Medicine in last year. And they're well into the phase 3. And this is the drug that we anticipate. We'll have to see how phase 3 goes, but this is the drug we anticipate may be first to market in terms of a new viral therapy for hepatitis B. So remember, they're going for a finite therapy here. So what they've done is they've taken both nucleoside analog treated and treatment naive patients that were e antigen positive and negative. It doesn't really matter, but all of them had to get to be e antigen negative and be suppressed to be able to come off treatment. And so what they show in these bars here is on the 2 doses that they looked at, and this is the 300 was the one that ultimately was chosen to move forward. And what you can see that the rate of S antigen loss with treatment of 24 weeks in this case led to about 10% of people losing surface antigen. Now, when they did a sub-analysis in those individuals who had a hepatitis B surface antigen level that was less than 3 logs, at the start of treatment, then their S antigen loss rate went up to 65%. So clearly where you start out in terms of your S antigen level is going to influence your likelihood of being able to lose surface antigen with treatment. Now, some of you may say, well, 10% doesn't sound very impressive. But I would just remind you, right? This is just 6 months of treatment. So you're taking a patient who's been on nukes for years. Now you give them 6 months of this drug, and 1 in 10 of them will lose surface antigen. Right? So it's not great. Maybe we could say we want better. Clearly, I want 100%. But this is a very good start, I'd say, for where we want to be able to go. So this now has a phase 3 study. And interestingly, they've selected patients who, in fact, have that surface antigen level that's 3,000 or less. Right? So they targeted the group that they think will have an S antigen loss rate that's going to be greater than 50%. So that's the anticipated outcome of that study. It just finished enrollment, so we're now awaiting the results. I wanted to also just highlight that there's a lot of immunological drugs, and I think these are very exciting in terms of alternatives. These are not likely to be drugs that are used alone, because what we're already seeing is that there's a combination therapy is very quickly coming into the drug development space, and we see them combining nucleoside analogs with a drug to reduce surface antigen with an immune modulatory therapy. So kind of trying to do all things. But there's really interesting drugs in this class. I'm not, again, going to go through all of them in detail. I just wanted to give you a flavor of kind of how the drug development space is evolving. So this is a very complicated looking slide. It's the way that phase 2 studies are being done now, where they really are looking at various combinations, trying to get a signal on which of those combinations to move forward. And what they've done in this study is they're studying an siRNA, as well as a TLR7 agonist or PEG interferon. So it's a kind of a complicated study, but that's kind of where you can see that they did the siRNA alone, they did the siRNA with a TLR7 agonist, and then one with siRNA and PEG interferon. So they kind of are trying to say, well, which immune modulatory drug is kind of the best here? And again, using nucleoside analogs, an siRNA, and an immunomodulatory therapy. So just kind of giving you a flavor of how they're starting to think about doing combinations. This treatment was given for 48 weeks. So the other thing that we're seeing in terms of drug development is they're now moving away from 24 weeks, which we saw with bepirovirsen, to now doing 48 weeks of treatment. But just to give you a flavor of how this is going to take us to where we want to go, you can see that in this study, the ones that received the siRNA plus some form of immune modulatory therapy, and in fact, PEG interferon in this case turned out to be the best immune modulatory therapy. In this study, you can see that in terms of S antigen loss, 23% of patients lost surface antigen. So now we're getting up to 20%, right? So it's really just to say the direction we're going. And truthfully, kind of what I wanted to do in just presenting these two drugs of many, many that are out there is to give you an idea of kind of some of the emerging concepts related to the new drugs. The first is that very quickly we've gone from maybe one drug to 2 to 3. So combination therapies look quite promising. And I think in particular, many of them are using some form of immune modulatory therapy as part of that combination. And right now, PEG interferon seems to be a front runner, but I'm hopeful there'll be better tolerated immune modulatory therapies going forward. Keep in mind that these are all finite treatments. So when they do these trials and you see them being treated, they're stopping the drug and then looking to see what those patients look like 6 months later. So that 23% I just showed you in the last study is what those patients achieve 6 months after being off treatment. So we all are having to manage patients that are going to be withdrawn. And although I didn't show you the data, there is a risk with flare with many of these new therapies. So we have to get expert at managing ALT flares. And then the other theme that we're seeing in terms of these new drug studies is they're going to target the low-hanging fruit, I call it, which is they're going to target individuals who already have surface antigen levels that are low, typically under 3,000. So you have access to quantitative surface antigen here in Canada. We also have it in the US. This should become something you get familiar with to understand where your patient is in that sort of journey of their surface antigen to know whether they're going to be potentially eligible for these new therapies. I mean, hopefully in the future we'll cure all, but right now we're focused on this very important group. And so I'm going to come sort of full circle and sort of link now the new therapies back to elimination. Because remember that part of our challenge with elimination, in addition to identifying people, but once we identify them, our current algorithms for treatment are really quite complex, and we have this kind of need to be on therapy for indefinite periods of time. So I think that there's a very exciting new pipeline of anti-HBV drugs that are giving us a glimpse of the ability to get functional cure with a finite course of treatment. And I'm 100% confident we're going to get there in the next decade. And this is going to allow us then to have more people just do one course, kind of one and done. I think that's going to change the landscape in terms of how we are managing patients. I think you can anticipate that when we have more drugs, we're also going to have to do a more individualized treatment approach than what we currently do, which is kind of three nucleoside analogs. They choose between the three. But, you know, I think the reality is that most of the disease burden for Hep B is in Africa and Asia. And so cost and access are going to be big barriers in terms of getting elimination to those countries. And so for that reason, NA therapies, which have been with us since the late 1990s, will remain a cornerstone in many countries for the years to come. But here in Canada and here in the United States, I think we, in the year between now and 2030, are going to see a lot more people getting functional cure.
Dr. Bain?
Thank you, Nora. Great talk.
There you are.
She functional cure, can they be removed from HCC surveillance?
We won't know that, I don't think, until we get there. I was chatting with somebody about this already here, because I think it's like a key question. It's a bit like our Hep C patients, right, who get SVR, sustained virological response, and those that have sort of stage 3 fibrosis, we're not sure what to do with them in terms of HCC surveillance as well. My own sense would be if we treat people before they have significant fibrosis and they're young, that there may be some opportunity to eliminate HCC surveillance in a group of individuals. But I think what's going to happen is we're going to get functional cure and we're still going to have to do HCC surveillance until we define what the risk is. But based on the longitudinal studies about spontaneous loss of surface antigen or under NA therapy, the risk for HCC is really close to zero. And especially if they lose surface antigen before the age of 50 and they don't have advanced fibrosis. So I can envision that in the future, we will have a group of patients we're going to say, you need to continue surveillance and you another group that's going to say you can stop. But I think we're going to have to cure people early, like earlier than age 50. And I think we have to cure them before they have significant fibrosis in order for us to eliminate the risk for HCC.
What are you doing today? And the reason I ask is one of my patients.
Oh, for
That's-
losing surface antigen.
He's lost it spontaneously. I was waiting to call him after your talk. But I need to know whether I can stop the, so what would you do right now? I know we don't have the data.
I would continue to do surveillance.
Yeah.
Well,
Okay.
but I would do that. I also have those patients. They're really lovely, actually, right? When you do have one, you go, oh, right.
Do the happy dance.
You are, yeah. And I mean, I think it means it's very meaningful for patients. You know, I do a lot of work with patient groups, and they talk a lot about the importance of functional cure from the point of view of reducing stigma and really allowing them to kind of, you know, in certain workplaces and other settings where like not having Hep B is really very meaningful for them. So I think really it'll be very important for the patient community too. But right now, we don't know enough about, you know, kind of individuals who lose surface antigen on treatment to know whether we can stop surveillance. I'm not stopping. Is that a microphone? Is that what the box is? Oh,
Oh, okay, okay.
I wasn't sure what it was.
Amazing. So, and you hinted a little bit about this in your last slides, but the question is about how do you balance? Because we are, for example, even in Canada, we are doing very bad in reaching some groups of people that have hepatitis B. You know, you show 12%,
Yeah.
I think, of
Yeah.
adequate treatment. So, you know, resources are limited and the new therapies are going to be very expensive. So how do you balance when these therapies arrive, keeping, you know, trying to put resources in reaching those now untreated populations versus favoring the new therapies?
Well, if I was, you know, if you have a limited amount of dollars, I would put it into finding the people. I mean, the problem we have is really, I think there's so many people that are undiagnosed. So that means that they're not aware of things they can do for liver health that might be important, right? We missed the opportunity to do surveillance for cancer, which, you know, really is an important component of how we are trying to reduce the morbidity and mortality related to this disease. So I think if you have limited dollars, I'd be trying to figure out how to maximize your ability to identify individuals. And, you know, screen all sounds great. You know, like we brought that to the US, you know, we have a new recommendation to just screen all adults once, but even implementing that in the United States it's a big undertaking, right? You know, primary care doctors are very busy, so add one more thing to their list of things they have to do, it takes time, but we're going to work towards that. That is the biggest gap, actually, still is in diagnosis. And the reason I say focus on diagnosis is if you look at individuals who they're diagnosed, and now you're trying to decide if they're treatment eligible, it's only a modest proportion of the patients. It depends a little bit on where you're studying, but a large proportion of those patients aren't treatment. They don't need treatment, but they do need to be identified. They need to be put into surveillance programs. They need to be monitored towards a cure, right? But actually, even when we have functional cure, we're going to be giving it to a select number of people. So it's really getting people into a program of monitoring to know when to intervene with treatment is probably the second. First, find them. But of those that you find, not all of them are going to need to go on treatment. And even when we have functional cure is going to be really stepwise for us, right? We're going to target the people that now target for treatment. Eventually, we'll get to everybody who has surface antigen, but it's going to take us, you know, decades probably to do that. We're going to struggle with it, you know, we're going to struggle with it in every country. These new medications are going to, you know, they'll be more expensive. Nucleoside analogs are cheap. They're very cheap. So I think it'll be interesting to see how that, you know, what the cost looks like when they roll out these new drugs, because you can envision they're going to do the modeling to figuring out the cost of long-term therapy, long-term monitoring, and the additional benefits of surface antigen loss in terms of cancer and liver transplant, for example. That's the kind of modeling that's going to go into how they're going to price point this, like what the price point will look like. We'll see. 100%, 100%. And that's the other component, actually. And thank you for highlighting that, because, you know, the other reason to screen, right, is you find the people that are still at risk, right? So that is the other element, because honestly, that is the fix, right? If we are successful at vaccination programs, then all of this managing of chronic disease goes away. There's always we have other liver diseases. You may not know about them, but no, I'd be very happy if we could actually make hepatitis B become a non-issue for hepatologists, infectious disease, primary care physicians. We all are dealing with these patients. Love to see it disappear.
So.
Can I ask Dr. Terrell to speak about? I'm very thrilled to see you here. Thank you.
Oh, it's great to watch and see what's happening in there. I have retired from clinical practice now, but still follow some of the research in the area, and it's interesting to see. Certainly, the functional cures are different than the chronic suppression.
Correct.
And before I left practice, I had some patients getting functional cures. It was very nice for them and
Yeah.
nice for me to see that happening.
Yeah.
But the evolution of therapy for hepatitis B has been interesting.
Yeah. And getting more interesting as we go forward now.
Yes.
What I didn't highlight, but I would say that the data I'm showing you where you get a functional cure 6 months post-treatment in 10% and 20%, that is the endpoint that the FDA is requiring them to meet to qualify, right? To call their therapy effective for achieving functional cure, they must show results at least 6 months off treatment. But I think all of us are aware that that might not really reflect the long-term kind of outcome of treatment. That maybe if you look at them a year later, 2 years later, that some of them may get seroreversion. We don't know that, right? And we also don't know, is somebody that gets functional cure through a new mechanism, is that going to be the same kind of functional cure as somebody who did it spontaneously, somebody who did on new? So these are all unanswered questions that will, as we get more functional cures, we can start to address. But just so you know that this 6 month is really for me, it's sort of a low bar, really. 6 months off treatment to show that, okay, you've got surface antigen loss. And that if you take them out further, we may see some that will not sustain that loss of surface antigen. So it's early days. 6 months is a reasonable endpoint, but it's, probably not as long as we would want. I think we'd want to see, similar to, I think back to the Hep C days, right? Where initially we required we had to get the data to show that what you had achieved at 12 weeks after your cure was still there 2 years later. We're going to need to do the same thing with hepatitis B. We're going to have to show that what you see at 6 months is still there 5 years later, that kind of idea.
How well do your patients tolerate the interferon when you go into that?
Yeah. I was really happy when we sort of moved away from interferon, to be honest. But, I always tell people I got to know my patients really well during PEG interferon. It was like you were in like a battle together. You saw them very often. You're like really managing a lot of side effects. And so, there was a closeness and a sense of achievement when you kind of got through it. So I think it's going to be a difficult sell, actually, to patients and providers to use interferon. I think they're using it right now, to kind of, it's a proof of principle that immune modulation is helpful to get us more S antigen loss. And I think that's helpful. And I think as the drug developers right now are trying to really move quickly to kind of figure out what their strategy is. But what we really need is an immune modulatory therapy that is without as much side effects. Only then will we be able to sort of really bring that to patients and say, this is what we're going to be using to get you to cure. But that's a very North American phenomenon, I think, to be honest. When I talk to individuals from China, for example, and even in Europe, they're much more okay with interferon. And in fact, most of the PEG interferon add-on and switch studies that I presented to you come out of Asia. That's where they're really, really very focused on that. And when I talk to colleagues there, they say they're happy to embrace PEG interferon as part of a cure strategy. I just think it's our hardest sell here. Yeah, that's right. That's right. Yeah, exactly.
Well, Dr. Terrell, thank you very much for an amazing lecture this
Thank
morning.
you. My pleasure. Yeah.